Hi, Chong. I'm here representing Patient Outcomes Department. I'm one of the ADAs. You'll see me in the medical center. There's a few of us. Our main role is supporting you in code stroke, code blue, rapid response, code sepsis events in the med-surg step down tele units, and hopefully facilitating patient transfer to critical care if needed. So the topic is early recognition of deterioration in patient condition. Thank you very much for inviting us to be present at your professional practice this 2022. Objectives. Understand criteria to when to call rapid response and to increase rapid response calls and decrease failure to rescue events. We're hoping to improve communication to other disciplines such as physician and to your intensive care counterparts as appropriate. We want to make sure we increase your confidence in both recognizing events of clinical deterioration and skills in emergent events. So did you know that 84% of hospitalized patients do not suddenly code and go straight into cardiac arrest? There are observable signs and symptoms that you can still visualize on patient deterioration 6 to 24 hours before cardiac arrest, which happens in med-surg. Experts reported about 68% of hospital cardiac arrests and respiratory arrests are actually avoidable. So we want to make sure we utilize evidence-based practice, such as the use of rapid response systems, which we have here at KP-LAMC, and it's helpful to bring the critical care expertise at the patient's bedside. The goal is to prevent deaths and improve patient outcomes. We want to make sure we identify signs of deterioration which can prevent avoidable code events. Delays in rapid response system has been linked to mortality, so let's avoid that. Who can make a difference in that is you guys. Make sure that you manage patient deterioration rapidly and recognize them as soon as possible. Critical thinking is the ability of the nurse to act on what they know and understand. So raise your hand, pick up the phone, push your Sarah. I'm concerned, I'm uncomfortable. This is a safety issue. Something is going on. And rapid response calls to your patient outcomes counterparts. It's a nurse to nurse consult, so you don't need a physician to call us. So when you're uncomfortable, just give us a call. Just sharing with you our data in the last 4 years. I presented this in the critical care committee last quarter, so this data is current, includes first quarter of 2022. So as you can see, there is actually increasing in rapid response calls in the last few years. Guess what? COVID did increase our rapid response in 2020 as well as 2021. More in 2020, of course. We didn't have vaccine back then. So this snapshot shows you in pink, essentially the 2020 effects of COVID. April, we had peak calls of rapid response calls, and then actually peaked in December of that year. Next slide actually shows the breakdown, the impact of 2020, the COVID-19 pandemic. So initially, April 2020, we started to have a rise in calls of rapid response, which pretty much took a peak in the end of 2020 as peak COVID was for all medical centers across the globe. In 2021, we finally got the vaccine, Moderna, Pfizer, thank God for us in the United States. And so vaccination actually decreased the amount of COVID calls, rapid response. Patients actually did a little bit better towards the summertime. And towards mid-year, we started the effects of the Delta in terms of the virus. And then later that year, the Omicron started to occur and make an impact to us as well, but not as badly as it was in 2020. So a deep dive in 2020 in terms of rapid response calls. So most patients transferred from tele to critical care. So back then, um, we transferred patient right away to critical care as soon as they have respiratory issues. As you can see, the transfer essentially occurred and decreased towards the end of the year because um, towards December, most of our beds are actually coming to max capacity. So we had a difficulty at the end of 2020. So most of you who actually were working during that time, you guys know that most units was maximized in terms of patient care. There's some rooms that actually had 2 patients, private rooms that became 2 patients in those rooms. So it was quite a struggle during that year in 2020. In 2021, with vaccination, we actually did a little bit better. So tele to critical care, essentially some of it did not happen right away. We had patients transferring to step down and observed there prior to going into critical care. So as much as possible, we want to move the patient along the continuum and avoid the tele to critical care right away if we do have step down beds, which is 6 East unit for the most part. So rapid response per RRT per department, since this PU is pretty much for our telemetry departments. 7 West has a lot of calls, and in 2020 as well in 2021, as you can see. The dark yellow is actually 6 East, but the light pinkish yellow is the 7 West. As you can see there, 7 West does have both neuro and cardiac patients. So those contribute to the amount of rapid response that's being called from those departments. So that pretty much is synonymous to the patient population that you do have in your units. So in 2022, the data is pretty much reflective of the same. So most calls are coming from the units that has the cardiac patients, along with respiratory involved patients as well in those departments. Patient outcome data from 7 West, this is pretty much what it is. Cardiac patients, about 41%. Sometimes the patient just goes VFib, because of heart attacks on the units that has cardiac patients. So that's why that contributes to a setting code blue. So respiratory, we had 22% coming from the 7 West. So in terms of the other side of the coin, neuro changes. Neuro, since 7 West is a neuro floor, you do have patients called for rapid response for 7 West. I do want to remind you that make sure to consider checking the blood sugar, making sure the patient is not hypotensive, and, essentially in terms of before you trigger your neuro consult for neuro patients, the BFAST symptoms needs to be persistent despite ruling out those 2 factors, hypertension and blood sugar, hopefully within normal limits, because that can be a factor too for that can change the neuro status of patients. So just a reminder, I know 7 West is actually very good in stroke trained, so you guys know that. And you do have neuro patients there, so your unit does have both type of patients, cardiac and neuro. So that's why the incidence of these patients are a little bit more on 7 West. So transfers to a higher level of care occurred about 72% at a time from the rapid response calls that is pretty much called from 7 West. So these are historical data. If there's any questions, you can reach out to me. My email is at the end of the presentation. So in terms of recommended criteria call for rapid response. So these are just guidelines, but when in doubt, just call us. So a patient's heart rate that is elevated, tachycardia or bradycardia, respiratory rate that's accurate tachypnea, or pretty much those are patients that are not breathing as much, maybe due to neuro or whether it's sedation and you're concerned, do call us. We do have some protocols, but we are limited based on physician orders that we have as an order set. You are supposed to also make sure you escalate and inform the primary physician alongside the patient outcomes. But go ahead and Sarah page us for rapid response. Um, More importantly, page us actually that pretty much makes us stop our workflow if we're actually doing something and run to the patient of your concern if you think that this is an actual distress on a patient. So oxygen saturation less than 90% is not normal on most patients. So make sure that you escalate those concerns of yours as well. So mental status change, the BFAST symptoms, if they do have persistent of those, then you consider the neuro physician as well. And that is the 279-1000 pager number for the neuro resident. I'm sure you guys know that by heart, and it's on our telephones on the nursing units. Urine output that is low, that's also a concern. So something that we can help you with, troubleshoot, that's another thing that you can call us for. So generally, any high concern for any of these particular conditions, don't hesitate and just inform patient outcomes. We can hover through the patient or browse the chart, make sure that there's anything else that we can do prior to the physician also making that judgment calls for the patient. What we use for patient outcomes, we do use the deterioration index. Goals is patient deterioration by proactive interventions for patients. This is something in Health Connect that we can put our toolbars and set. We monitor the patients every 2 hours on med-surg units, and we look at their deterioration index. And if the deterioration index value is escalating, and usually that number is 60 and above, then we try to recognize whether this is a new change or a chronic one already. If it's a new change, we usually try to intervene and troubleshoot what is going on in these patients to avoid deterioration. So this avoids the transfer to higher level care if we intervene early. Our goal is that decrease RT events that turns into cardiac arrest. Although patients exhibit clinical signs of deterioration up to 8 hours, unplanned transfer to ICU often result from failure to recognize clinical condition. So we want to make sure we're always thinking, and we're supporting you by just hovering over the charts too, as like I said, for the med-surg tele areas at the medical center, as well as step down. This is an example of the proactive rounding that we do for patient outcomes. So we do monitor what we call a new score. New score is actually the older version of proactive rounding that we do, but we still look at it and recognize that that's a different system than the DI score. DI score is another tool that we use. They're both available in Health Connect. You can add them to your toolbars in terms of your patient's chart. So if the numbers turn into a red color, that pretty much is alarming if it's new. That means it's a new onset. Is that we need to troubleshoot what is contributing to those numbers, and hopefully we can intervene, and hopefully those numbers turn back from red to hopefully yellow and back to green. Green, it means that the patient is stable according to those numbers. But as you can see, new score and DI scores are two different entities, so that sometimes you do need to consider both and other factors with it. Part of those numbers are on the right hand of the screen, which you see pulse, blood pressure, respiration, O2 sound. Those are vital signs, and laboratory values also contribute to those values. As you can see, this is more of a snapshot of what contributes to a high DI score. As you can see on your left-hand side, moderate is 40 to 60, 59, and 60 and above is high score. So what factors are part of the deterioration index? And that pretty much includes the patient's Glasgow Coma scale. So whenever you chart and document the Glasgow Coma, on patient's flow sheet and update the vital signs, and then the patient has new labs, the DI score is pretty much updated automatically in Health Connect. And you can monitor this yourselves, but patient outcomes also monitor these on the periphery. We monitor at least every 2 hours on these patients' medical charts for med-surg tele areas and step down. Expectations. So expectations is page rapid response. Ideally, like I said, you page 3000 in order to alert appropriate channels so that we can stop what we're doing and attend to the patient as soon as possible. If you truly feel this is a patient distress, we will be there to check on the patient. Primary nurse responsibility is to give an SBAR report. You guys know that's the most effective way of communication, the SBAR report. That means the situation S, explain the situation. A, the patient tachycardia at this time. This is a new onset. Background, they're admitted here for chest pain. They don't really have medications yet ordered by the physician. Right now, they're short of breath. That's your assessment. And then perhaps, help us, stabilize the patient while we're waiting for the physician to arrive. So we'll come to you as soon as we can. We'll troubleshoot and order basic labs, x-ray if needed. Some medications, though, some physicians are very nervous. There are different kinds of cardiac medications that can be given, different classes. So if the patient is stable, has a good blood pressure, it's not an emergency in terms of patient, needing electrical therapy or anything like that. So they sometimes would want to wait. So we don't have those medications readily as part of our standardized protocols. So we do need physician to arrive and order those. But for ASLS medications, those are within our means. If needed be, we need to be present and can be the code leader for you if this is truly one of those deterioration events. I do want to caution the primary nurse need to always know the patient's code status. Is the patient DNR, DNI? What are the limitations to the patient's wishes? And if truly the physician said or the family doesn't want any more heroics on the patient, should the patient be in comfort care? So that's a discussion that should be done already or needing if the patient doesn't want heroic efforts. But that can only be shared on an emergency by the primary nurse. So I'm hoping that you guys would know that when you give us SBAR report. So charge nurse. Charge nurse are knowing who to contact on your unit. Each floor has a different physician hierarchy in terms of who to call. So that really helps us contact the right physician to be at the bedside. So when you do page patient outcomes, go ahead and call the physician that is basically in charge of the patient care. And as you know, the patient can be a different service, whether it's cardiac or neuro or surgical type of patients. So notify your physicians, please, of any RRTs that occurred, whether it's day shift or night shift. A lot of the times, well, actually not a lot of times, less. There are some now, there's less occurrence of the physician not knowing nowadays. In the past, there were a lot of physicians who say, hey, by the way, we had a rapid response and there's documentation, but no one informed us. So that's truly alarming. Please do inform your physician of any calls for rapid response because, of course, they care about your patients as well. So they want to make sure they're connected with the care, and we want to make sure that communication occurs. And again, you know who to contact more than patient outcomes. So we give that to you as a responsibility for contacting the correct physician. So vital signs, make sure that you can tell us, what's the vital sign currently and historically for this patient that will help us troubleshoot in terms of what to do for the particular call that we get. One advice, the patient does a snapshot button in Health Connect that you can review home medications. A lot of the times the patient home medications um, is not being given to them in the hospital and they need to resume that. So that's something that you need to also consider. And most of the times that's a factor that is missing for the patient care is some of the medications that they were already on at home and not um, resumed in the hospital. So anyhow, that's one thing that usually helps them. Um, that is one of our findings. So early prevention and prioritization in terms of patient, the handoff, make sure you give a handoff to us and inform us of any issues that were occurring beforehand, some labs and imaging that was probably pertinent to the care, share that with us. One other thing for cardiac patients and respiratory patients is very important to always have suction in the room. You never know when the patient is going to need airway protection or intubation. For if it's truly a cardiac arrest, of course they're going to need intubation. So you want to make sure there's always some suction set up in the room for a newly admitted patient in those departments. Um, Also make sure that you're monitoring the patient appropriately. If there are any type of parameters that needs to be done for patients, whether or not they're chronic or new bradycardia or tachycardia, do curtail your alarms to make sure that you are not just hearing the new alarms um, when at the chronic times essentially. You want to make sure that you're alerted as well of new alarms for a particular patient. IV. No, IV is very hard to give heroic medications if you don't have existing and patent IV. So it is all our responsibility to make sure the patient has a working IV all the time while they're in the hospital. Um, so we do have the PIC nurses who can assist with that. We can assist as well, but not everyone is trained in patient outcomes. For putting the peripheral IV with using the ultrasound IV, I know that's a skill. We are being trained to do IOs for emergency. So just to help us for those particular occurrences. But it is helpful to make sure you do have a pain IV before an emergency occurs. So just a reminder, that's all of our responsibility. I wanted to just share with you some of our code blue data from the past 4 years. As you can see, the code blues did decrease with our increase of rapid response, which is actually a good trend. COVID-19, of course, added to the code blue calls in 2020 and 2021, which is just shown here in the data. But as you can see with the slope going downwards, as you can see, there's slope going downwards in terms of 2021 and amount of code blues that are called. So that's a good trend for our medical center. Blue in non-critical care unit, which is med-surg. Essentially, this shows your data. As you can see, it's been stable and actually lesser as COVID declines. Hopefully that continues this 2022. So acute respiratory compromise, which is basically respiratory code blue, this is just showing the data from 2018 to 2021. So of course, patients have ventilators in 6E, so that they do have a little bit more of that data. But as I mentioned earlier, if you have patients who are respiratory because of stroke, they're bradycardia, you will probably have some of this stress sometimes. And for patients with COVID-19, that also adds to the respiratory compromise. So that adds to the data here. But it's been stable pretty much the last few years. So it's not an alarming concern. Our quarterly data in terms of code blues. Again, they're Q3 of 2020 and Q4 2020. In the beginning of 2021, we do have more events of both ARCs and code blues, and that's because of the COVID pandemic that we have experienced. And hopefully it continues to decline. I would like to share with everyone that we report to American Heart all the code blues that happens in our medical center. We actually do a deep dive and look at the medical chart for these patients, and we abstract everything, patient information, and put into their registry essentially. And this gives us our data with 2021 and 2020 comparison. Our time to first shock, less than 2 minutes for VFib, pulses VTAC, first documented. As you can see, the data on the left, our number was 60%, above 60% in 2020, and we actually declined to only 50% this 2021. 2022, which we're currently in, that's something that we need to work on. We need to make sure that patient goes VFib or VTAC, that we need to defibrillate within 2 minutes. So however that we can do to facilitate that, that's part of the reason why we're presenting to you, to hopefully that you are aware that that's something that we are being measured. We want to make sure that we do defibrillate the patient early because every minute of lack of defibrillation for a patient, we decrease the chance for survival by about 10%. So that's very important that we need to improve on that measure. Now the other measures, time to IV, IO, epi less than 5 minutes. It's actually been stable in the last few years. We're doing very well, as well as percent pulses cardiac arrest monitored or witnessed. We're witnessing most of this deterioration. That's also 100% for us. In terms of airway confirmation device in trachea by hospital, our numbers have improved since last 2020. We went from 60% to about 90%. And that's just making sure that when we intubate a patient, we want to make sure that it's not just auscultation or pulse oximetry that we're recording and documenting. On the code blue sheet, we need to make sure that we also document the end-tidal CO2, that the detector device is actually yellow. Yellow is gold on the ATCO2 detector, and documented on the code blue record. I know in med-surg you don't have the ATCO2 electronic or visuals. Essentially, that will be only in the critical care department that they would have those monitors for ATCO2. But in med-surg, you do have access to those EasyCap detectors, so make sure you document that on your code blue sheet. It's very important to make sure the patient is really intubated and secondary device to confirmation of airway. So this is just the deep dive breakdown of our actual numbers that I mentioned from 2020 and 2021. So the first and last one, that's actually what we need to target for this particular improvements for 2022. The time to first shock, less than 2 minutes, and confirmation device usage of anti-CO2. We want to promote more use of that. So deep dive, how can we improve further and impact patient care? So as you can see, I blocked out the medical record number on the left, but as you can see, some units are showing here who did not defibrillate the patient within 2 minutes. So it's showing you here CCU, recovery room, neuro ICU, 7 West is actually on here. There's a patient that was defibrillated and it took 6 minutes before the patient was defibrillated. So what was the cause of that? We have to avoid that in the future. We shouldn't, really worry. We're covered by ACLS that the patient is VTAC VFib. You confirm that it's VTAC VFib. That patient needs to be defibrillated right away. So common findings with the guidelines, again, promote early defibrillation, promote quality CPR, essentially. That's why in critical care, we want to make sure that they're using the end-tidal CO2 detector device readings, because if the patient still needs continuous CPR and they're already intubated, the readings would validate that the patient's airway is actually still intact while the patient is being resuscitated. So that's very much an American Heart Standards. Also, American Heart Standard is strict documentation, capture of initial EKG onset. What was the initial strip? Was it bradycardia? Was it VFib? Was it asystole? That initial strip really needs to be found and documented. recorded as possible. And I know we do have Water Tech virtual right now, so that strip documentation process is in review. Who will be responsible for that? Primarily, it should be the primary nurse or charge nurse helping out the primary nurse to make sure that that actually is recorded. Patient outcomes, we do help to make sure that that is done. But sometimes we are called to different emergencies at the same time, so we really need assistance to from everyone, and everyone needs to help out essentially for us to be compliant with attention to patient resuscitation appropriately at the hospital. And lastly, for critical care, emphasize ETCO2 monitoring and documentation and coaching once the patient is intubated. As you know, there is the DOPE mnemonic, that's dislodgement, obstruction, pneumothorax, and an extubation or sorry, equipment failure that will occur sometimes even though the patient you thought was intubated, but probably wasn't appropriate. So that's why ETCO2 monitoring device is assures that it's still in place correctly. So those numbers will actually give us value whether or not it's still patient is still exhaling CO2 continuously, which is a measurement that the patient's airway is intact. So any questions to this, let us know. My name is, again, is Maya Chong. I'm one of the ADAs of patient outcomes. I don't work alone. I do have patient outcome ADAs with me, and night shift counterpart for CoBlue and RRT resuscitation is essentially Brittany Mobley. Our contact information is on here at the end. There's all of us in patient outcomes do help each other out. We do have several outcome measures that we're supporting in our medical center, but as a team, we're all here to help out the medical center and the nursing units. So we're all part of your units. So don't hesitate to reach out to us if there's any questions or concerns. Any interest on becoming resuscitation champion, particularly for your particular area, reach out, don't hesitate, and you can always come to us or be present in some of the meetings that we have to discuss how to improve our outcomes for our medical center. Well, that concludes my presentation. Thank you very much for having me. Hopefully you have a nice summer coming up this year. It is summertime right now. I know you're doing your PPU. I'm excited to continue helping and supporting your departments and hope to see you again soon, everyone. Take care.